Tell me something.
There's a neighborhood in Glasgow, Scotland. Male life expectancy 54 years old. 14 kilometers away, in a different part of the same city, the same country, the same health system, male life expectancy is 82 years old. 28 years of life expectancy, determined entirely by geography. This is not an anomaly. Versions of this pattern exist in Lagos and London, in Johannesburg and New York, in Port Harcourt and Sao Paulo. The postcode in which you were born is one of the most powerful predictors of when you will die. More powerful in most cases than your genetic inheritance. Before we begin, an important note. This episode is for educational purposes only. It's not a substitute for professional medical, psychological, or public health advice, diagnosis, or treatments. Content draws from an introduction to global community health psychology published by Routledge in 2026 and from peer-reviewed academic sources. Health science evolves, always consults current guidelines and qualified professionals. If you are experiencing a health concern, physical or mental, please seek qualified professional support. Links are in the description. Welcome to Global Community Health Psychology, the full course. I'm Dr. Anthony Iyore Anaweokhai, MBBS, MBA, MSc, MPH, PhD. Director of the Anaweokhai Institute for Applied Global Health, Port Harcourt, Nigeria. Series 1, Foundations, Episode 2. Today, we cover Chapter 8 of An Introduction to Global Community Health Psychology, published by Routledge in 2026. Chapter 8, Addressing Health Inequities Through Psychology. Your postcode predicts your health better than your DNA. In this episode, how social disadvantage becomes biologically embedded through the HPA axis and allostatic load, the minority stress model, and what chronic vigilance does to the cardiovascular system, structural racism as an epidemiological finding, not a political opinion, intersectionality and why single identity analysis misses the most vulnerable populations, and the Anaweokhai model, what community-controlled, structurally informed intervention actually looks like. If you work in health and you are not thinking about structure, you are treating symptoms and calling it medicine. Let us begin. The relationship between poverty and poor health is not simply about lacking access to doctors. It's about what chronic exposure to social disadvantage does to the human body. At a psychological level and at a physiological level, immeasurable, documented biological processes. The primary mechanism is the hypothalamo-pituitary-adrenal axis, the HPA axis, the body's stress response system. When the brain detects a threat, the HPA axis releases cortisol and adrenaline. Blood pressure rises, heart rate increases, immune function shifts. The body prepares to fight or flee. This is a healthy, adaptive response to acute stress. The problem is what happens when the stress is chronic, not a single threat, but a continuous background condition of financial insecurity, housing instability, exposure to violence, and social marginalization. Under chronic stress, the HPA axis remains activated, cortisol remains elevated, and sustained cortisol elevation does measurable biological damage. It promotes central adiposity, increases inflammatory markers, accelerates arterial damage, impairs immune function, and has been shown to shorten telomere length. The biological clock embedded in every cell. This cumulative physiological damage from chronic stress exposure has a name: allostatic load. Allostatic load explains why health disparities are not simply about behaviors. The social world writes itself into the body. This is not a metaphor, it is cellular biology. And research published in the Proceedings of the National Academy of Science confirms that allostatic load scores differ systematically by race and socioeconomic status in ways that directly mirrors patterns of social disadvantage. and that these differences begin accumulating in childhood. There is a specific mechanism through which belonging to a stigmatized or marginalized group generates health-damaging stress. It is qualitatively different from the stress experienced by majority populations. It has a name, the minority stress model. It was developed by Iyore. The model identified 3 levels of stress that operate simultaneously in marginalized populations. Distal stressors: number 1, objective discrimination and violence, denied housing, police harassment, workplace discrimination, verbal and physical abuse. Proximal stressors is number 2, internalized stigma and the psychological work of managing a stigmatized identity, the effort required to decide whether to conceal or disclose, to anticipate prejudice, to manage how one is perceived in hostile environments. And number 3, chronic vigilance, the sustained, physiologically costly state of alertness that marginalized individuals maintain in environments they have learned are not safe. Research demonstrates that anticipated discrimination, simply the expectation that discrimination may occur, produces sustained sympathetic nervous system activation that elevates blood pressure independently of whether discrimination actually happens. The evidence is describing something communities have known experientially for generations. Racism is not just socially unjust, it's biologically damaging. This brings us to the most important clarification in this episode, and the one most likely to generate discomfort. I want to be precise about something, not political, precise. Structural racism in an epidemiological context refers to systems of policies, institutional practices, and social norms that systematically advantage certain populations while producing cumulative adverse outcomes for others, regardless of individual intent. It is a structural phenomenon, not a psychological one. It does not require individual malice. It operates through the architecture of systems. Residential segregation is a structural phenomenon. When policy decisions, red line in the US, forced removals in South Africa, urban planning decisions across Nigerian cities, concentrate social and economic disadvantage in specific geographic areas, the downstream health effects are measurable, they are consistent, and they are generationally persistent. Alan Geronimus described the weathering hypothesis, the finding that the bodies of black women in the US show signs of accelerated biological aging that track systematically with socio-economic disadvantage and racial stress exposure. It's measurable in cortisol patterns, in inflammatory markers, and in telomere length. Structural racism is a risk factor for disease in the same sense that smoking is a risk factor for lung cancer. It's not a political opinion, it's a finding that emerges from applying the tools of epidemiology to population health data. Now, the analytical tools that captures what single variable analysis misses. Intersectionality. Here's something important about how we study health disparities and where the most common analysis fails. Kimberly Greenshaw developed intersectionality as a legal framework in 1989. It has since become one of the most important analytical tools in health equity research. Intersectionality does not simply mean that multiple disadvantages add up. No, it means that multiple marginalized identities create qualitatively different experiences that cannot be understood by studying any single identity in isolation. A black woman in a healthcare setting does not experience the genetic disadvantages of being black, plus the genetic disadvantages of being a woman. She experiences a specific, qualitatively distinct set of interactions shaped by how race and gender intersect in that specific institutional context that cannot be predicted by studying either race or gender alone. The evidence for this is substantial. The superwoman schema. The cultural expectation that black women demonstrate strength, suppress emotional expression, and succeed under adversity without complaint has been documented as a direct contributor to delayed healthcare seeking, to inadequate pain management, and to elevated cardiovascular risk. It is a phenomenon that only exists at the intersection of race and gender. It is invisible to single-axis analysis. An implication for intervention, one of the most important examples in this entire textbook, the Anaweokhai model. The Anaweokhai School's Diabetes Prevention Project, Quebec, Canada, a Mohawk community. Adult diabetes rates of 8.9%, more than double the provincial average. Rather than accepting an externally designed intervention, community leaders partnered with researchers on a non-negotiable basis. Community control at every level. Community members were trained as co-researchers and participated in every aspect of the program. The research design, the data collection, the analysis, the interpretation, and the dissemination. The intervention combined with traditional Mohawk health teachings with evidence-based diabetes prevention strategies. The outcome measures were defined by the community, not the external research team. Long-term follow-up demonstrated improvements in diabetes risk factors alongside a set of outcomes the standard research protocol would never have measured. Increased community cohesion, greater political engagement around health issues, and cultural revitalization. The lesson from Anaweokhai is not about diabetes prevention, it's about what happens when health research is designed to serve the community rather than extract from it. And an equation that brings the whole episode together, the prevention equation. Why do behavior change-only health programs consistently fail populations facing structural disadvantage? Community psychology offers a useful framing. Incidence of health problems equals organic factors plus stress divided by competence plus social support. Applied to health equity, this equation reveals the problem clearly. If you increase health literacy, the competence variable, without reducing the chronic stress that structural disadvantage generates, the overall equation does not improve enough to change outcomes at population level. Sustainable health equity requires simultaneous interventions at multiple levels. Any health intervention that ignores the structural level is not addressing health equity. It is addressing the consequences of health inequity while leaving the causes intact. One orientation. That is all this episode asks for. When you see a health disparity, a community with higher rates of hypertension, of diabetes, of mental illness, or premature mortality, the correct first question is not, what are those people doing wrong? The correct first question is, what has this community been subjected to? The science of allostatic load, the minority stress model, the weathering hypothesis, and decades of social epidemiology all point in the same direction. Health inequities are not primarily products of individual behavior. They are products of social systems that have been designed, whether deliberately or by accumulated neglect, to distribute risk and protection unequally. Addressing health inequities requires structural competency, not just treating the symptoms those systems generate. This episode is based on Chapter 8 of An Introduction to Global Community Health Psychology, published by Routledge in 2026. The full textbook is available on Amazon website and from Routledge at their website. Links are in the description. If this episode challenged how you think about health disparities, the book goes deeper on allostatic load, minority stress, intersectionality, and structurally competent intervention design. Episode 3 covers Chapter 12, Infectious Disease and COVID-19. The question we asked there, the virus was never the hardest problem, human behavior was. If this episode has been useful to you, here's how to go deeper. Subscribe to this channel at Anaweokhai Institute for the complete books to video library from the Anaweokhai Institute for Applied Global Health. New episodes every fortnight. The Health Dispatch, our weekly newsletter, goes deeper on every topic this series covers. Free and paid tiers exist. Link in the description. The Practitioner's Course in Global Community Health Psychology is available on Gumroad. 8 weeks. Everything this textbook covers, built for practice. Link in the description. And the textbook itself, An Introduction to Global Community Health Psychology. Applications at the intersection of health psychology and public health is available from Routledge and on Amazon. Everything begins there. Health is not destiny. It's been Dr. Anthony Iyore and Anaweokhai. I'll see you on the next one.